And what is the main focus of the phase 1 study?
Safety.
What is the main focus of the phase 2?
Efficacy.
Main focus of phase 3?
Safety and efficacy.
What is randomization?
Selecting patients
Subjects random.
randomly.
By chance.
Randomly selecting people.
Without any bias.
Without any bias, randomly selected people for the study. What is pattern study?
The subject has been given the same treatment throughout all the visits.
So if the subject has given the same treatment for the entire study,
Yes, sir.
That is parallel.
what is NDA? New drug application. What is
Application.
biological licensing?
Authority.
What is FDA?
Food and Drug
What
Administration.
is DCGA?
The control.
Control General of India.
What is ICH? International Conference on Harmonization. International Conference on Harmonization for the technical requirements for the registration of
Pharmaceutical products.
pharmaceutical products. We'll discuss that one later. I told you in the last class, by the end of the phase 1, you'll get a lot of data. By the end of the phase 2 also, you'll get so much of data. And by the end of the phase 3, you'll get huge amount of data. Isn't it? So when we have a huge amount of data, since we cannot analyze all the data by normal traditional methods, we use like any software tool to analyze the data. If you use any software tool for the data analysis, we call it an analysis tool. And I told you, according to the FDA guidelines, we have to use only science. This is what we have seen. Previously, all the pharma companies used to submit their report to FDA in their own way. So, for example, Novartis used to submit their report in one way. Taraxel used to submit in a different way. So, for example, Novo Nordisk in a different way, GSK in a different way. Each and every pharma company used to submit the report to FDA in their own format. Because of that, FDA used to take so much of time to review the application. In the starting, I told you yesterday, remember, when I discovered a new molecule, a drug, the first thing I'm going to do is I will apply for intellectual property right, patent right. I told you, remember how many years I will get the patent right? 20 years.
20.
20 years.
From the discovery of that drug to get the drug into market, it will take 10 to 12 years. So that means out of 20 years, you already lost 12 years time. We are going to left with only 8 to 9 years time. In that 8 to 9 years time, we have to effectively market our drug. Then only we get a good profits. Okay? And if the 10, 20 years period has got over, and now it's anybody can manufacture that one and can market that one. Now people like me, what they will do after the 20 years, they will get the drug, they will, powder it, and they will understand what are the composition that we have in that drug, and they will remix all the components and then sell the drug. And that is called generic drug.
Generics.
For so much of R&D, for so much of efforts, it is going to cost me, one tablet is going to cost me, say for example, 10 rupees for me, because I did so much of research, so much of R&D. If you do the generic drug, reverse manufacturing, the same one tablet for the for manufacturing of the same one, maybe it will take 1 rupee or 2 rupees. Even though you sell that one to 5 rupees, you are going to get so much of profits. Isn't it? So if you want to do anything, you have to do in the 20 years only. So that's why in the clinical research, time is so important. Time is very, very important. So if we take 2 years or 3 years time to review that application, so we as a pharma company, we are going to lose so much of time. You should not lose that time. So that's when the clinical research time is very, very important. And not only that one, initially, if you believe that 10,000 molecules has got potentiality to become a molecule drug. So by the end of that third phase, only 5 to 10 molecules will come into the market. See the ratio? 10,000 is to 5. The success is very, very less. 10,000 molecules will start phase 1. No. Market lo kuch 80 drugs vasthayi, only 5 drugs will come into the market. So the success is very, very less, and it's time to process. So much of money involved in process, so much of time, efforts, and money. That's why each and every company will take so much of care at each and every step. After that airways, what you mean by airways? Airlines and all the airways. The next, the most important, that will take most care, is going to be very, very stringent. The next important industry, that is the clinical research. We take so much of care, and each and every step we follow very strict guidelines to make it the drug to get into the drug into the market. Okay, and after the areas tarvata anta strict ga follow ayటువంటి ఏదైనా ఇండస్ట్రీ ఉంది, ప్రొఫెషన్ ఏదైనా డొమైన్ ఏదైనా ఉంది అంటే కనుక the next important domain is the clinical research, because so much of money, so much of effort, so much of time get involved in it. Understand this? And the most important thing is human health is involved in it, so that's why they take a lot of care. Okay, as I said, pharma companies used to submit the reports in their own format to FDA. Because of that, they don't know how the FDA is going to get the report. So once they got the report, they have to review that application. So because of that, FDA used to take so much of time to review that application. So to avoid such unnecessary time wastage, what they have done, now they started, all the pharma companies, they started developing their own standards. So now all the pharma companies decided they want to create an own organization, so to help them to follow the guidelines. And that organization, we call it as a Cdisc organization. All these pharma companies voluntarily they created an organization. And what is that organization is called? Cdisc. What do you mean by Cdisc now? The Cdisc means clinical data interchange standard consortium. should call it as not a consortium, we should call it as a consortium. Clinical data, interchange, standards, consortium. It is a voluntary, non-profit, multinational organization. Now, what this Cdisc will do? Cdisc will get information from FDA, how they want to have the report. If they want to have the report, what are the regulations, what are the guidelines the pharma companies must follow? So, to submit all the documents in a uniform manner, now they created this consultancy. It acts as a consultant between the FDA and the pharma companies. So they will talk with the FDA and they will get the information from FDA and they will supply that information to the pharma companies. To submit the clinical research reports in the uniform manner, now Cdisc has created 3 important guidelines. Okay, and those guidelines are called Sdtm, and the next one is Adam, and the third one is TLFs. And by the way, these are not guidelines, but we follow it as the guidelines. But these are not the TLFs are not the guidelines. Only Sdtm and Adams are the guidelines, but we also follow. It is not an official, not in a guideline, but we also follow those guidelines which are called TLFs, which means tables, listings, and figures. Figures are nothing but graphs. That's why some people also call it as the name TLGs. So Cdisc like proposing 3 important guidelines: Sdtm, Adams, TLFs. What is this Sdtm, Adam, tables and listings and graphs? Okay. So for example, whenever you conduct the clinical trial, you will get the data. And that data we call it as a clinical data. So since we got this data from a clinical trial, we call it as a clinical study data or a clinical data. Now, when we have a clinical data, we have to submit this data to FDA. Okay, we have to submit this data to FDA. How to submit this data? As I said, we are going to get millions of lines of data. How to submit? Of course, we are going to submit the data in a tabular format. So that means we have to submit as in a table. When you're submitting as in a table, how many tables you should submit? Can I put all the data in one table? So say for example, I have a 1 TB data, 1 terabyte data. Am I going to submit all the 1 TB data as one data set according to science? Or one table to FDA? Or do I need to submit 100 tables or 1,000 tables? Now, Cdisc proposes some guidelines. Now, what are the guidelines? So, during the clinical trial, some of the subjects may come across certain adverse events. Some of the subjects may come across some untoward medical occurrences. When we have such kind of untoward medical occurrences, submit the data, all the data in one table, and give a name of the table is AE. It means adverse events. So, say for example, if I have 1,000 subjects in my study, say for example, out of 1,000 subjects, 20 subjects got some adverse events. Submit this all the adverse events data as one table, and that is called as an AE table. Okay. Now, during the clinical trial, whenever the subject comes to the clinical site for a visit, every time I will collect the vital signs. Do you know what you mean by vital signs? Anybody? I will collect the height of that subject, weight of that subject, and I'm going to collect, say, for example, temperature of the subject, and I'm going to collect, respiration, and I'm going to collect, say, for example, systolic blood pressure, SysBP, and I'm going to collect the diabetes, and I'm going to collect BMI, and I'm going to collect this respiration and all this information. If you have such kind of vital signs information, okay, put all this information into one table, one data set, and submit as an VS. VS means vital signs. So that means whatever the data that you collect in a clinical trial, what we are going to do, whatever the Cdisc recommendations that we have, based on the recommendations, I will put this data, relevant data into one data set, one table, and I will submit the data. All the adverse events into one table, all the vital signs into one table. If I take any ECG information, ECG, electrocardiogram results, and I'm going to submit as one data set, which is called EZ. During the clinical trial, I'm going to conduct n number of tests, laboratory tests. If you have any laboratory tests, those lab test reports, and I'm going to submit in one data set, and that is called LV data set. So, for example, it is a diabetic study. Every day morning, the subject should take one tablet, and night one tablet. And this is according to my study. Whoever involved in my study, every day morning he has to take one tablet, night one tablet. And suddenly the subject has got fever. Okay? To come out of the fever, what he will do? He will take some other medication. That medication is not according to my study. He has got some other problem. To come out of the problem, he has taken one medication. And that medication we call it as a concomitant medication. We call it as a concomitant medication. If you have such concomitant medication information, we have to put all that information in one domain and one data set. We have to submit as a CM. Say, for example, I'm taking one more subject called X. He's a diabetic patient. He involved in the diabetic study. According to my study, the next 90 days, he has to take one tablet in the morning, one tablet in the night. That is according to my study. But he has got thyroid problem also. Every day, what he has to take, he should take one tablet every day morning. And that is not according to my study. He has got some other problem. For that problem, he is taking the medication. And that is also called concomitant or prior medication. That information also, we are going to submit in a data set called CM. CM means concomitant medication. So that means in the clinical trial, whatever the data that you got, we are going to submit all the data in the form of few data sets. What are these data sets? Now, Cdisc will tell you what are these data sets. According to you, what is a data set? As a SAS programmer, a data set is going to have variables and observations. You don't need to worry. What are the variables you should have? They will only tell you. So, we take data into which variables you should give the data, how many observations you should have, they only will tell you. So, as a SAS programmer, now what we should do, whatever the clinical trial data that we have, clinical data, and now as a SAS programmer, we should put all the data into different data sets. So, now by following the Cdisc guidelines, whatever the guideline that we have given by following the Cdisc, okay, by following the Cdisc guidelines, by using your SAS programming skills, you have to transfer all the clinical trial data into different data sets. And if you're doing that one, and that is called as an Sdtm. You know what is the full form of Sdtm? Study data tabulation model. Study data tabulation model. Once you submitted all the clinical data as in a data sets, most of this data is unfit for automatic operations. Since this data is unfit for automatic operations, now what you are going to do, again we are going to transform this data as an analysis data sets. First we are going to submit as an Sdtm data sets, then we are going to again transform the data set as an analysis data sets, and those data sets are called ADAM datasets. Now, what is the full form of ADAM? ADAM means analysis data models. Analysis data models. And once you submit the analysis data sets, again, what we are going to do now by using statistical concept, you remember that we have learned to use statistical procedures like proc means, proc frequency, proc univariate, and we are going to have proc t-test, proc survival analysis, and proc regression. By using those statistical concepts, we are going to analyze this data and we are going to create analysis tables. We are going to submit those analysis tables. And those are called, I told you, we are going to have TLFs. In the TLFs, the T stands for these analysis tables. Now, whatever the data that you submitted, we are going to print those data sets, and those prints are called listings. And finally, whatever the report that you got, we are going to submit those reports in the form of graphs, and those are called F. So F means figures or graphs. Now, by using these analysis tables, listings, and graphs, we are going to fill an application called, I told you yesterday, we are going to fill an application called NDA or BLE. And now we are going to submit this NDA or BLE to FDA. Now, FDA is going to take 6 months to 2.5 years time to review your application. If they believe that if a drug is really did well in the humans, there are less and less side effects, more and more benefits, then they will give the permission to manufacturable data and to marketable data. By using GCMP, good manufacturing practices, we are going to manufacture the drug and we are going to market the drug. Now, sometimes what the FDA will do, even the drug went into the market, they will ask you to submit the data from the hospitals and patients, and again, they will review the data because of, how much time it will, you might have conducted phase 2, maybe 2 years, phase 3, 3 years. Altogether, it's going to be only how much time? 5 years. But what if I use this drug for long term? So, for example, if you have a diabetic problem, how many days you should use the medication? Probably you should use until you die, isn't it? How this drug is going to work if I use for 5 to 6 years, after 5 to 6 years, maybe after 10 years. So that means how the drug is going to, what side effects is going to show you when you are using for long term. Isn't it? Certain medications, so you have to use, say, for example, take BP tablets. So you have to take that medication until you die. Isn't it? So once you have got that problem, you have to use it. So when you're using the medication, maybe for 6 or 7 years or more than that, is it going to show any side effects? So that means they want to know about the long-term effects. Okay, they want to know about the long-term effects. So for that reason, every now and then, they will ask you to submit the data once the drug went into the market also. So we need to collect the data from the hospitals, from the patients and the doctors, and we have to submit those reports again. And this is called, what you call it as a name? This is called as a name, phase 4 studies. And we also call it as a name, post-marketing surveillance studies. Post-marketing study. Pardon? Didn't get you?
Got it, sir.
Okay.
Full form of BLE.
Biologicals licensing application. Now, as a SAS programmer, it's your duty, whatever the clinical trial data that we have, you have to transform that into Sdtm datasets And again, those SDTM data sets, we have to transform that into Adam data sets, analysis data sets. And again, from that, we have to analyze data and we have to submit the tables, listings, and fields. Okay. Now, submitting from the clinical trial data to get the permission from FDA, there are going to be around 9 to 10 positions. All these 9 to 10 positions are belongs to the clinical SAS program. So as a SAS programmer, if you complete that Cdisc project, you can apply for any of these positions. Okay, there is going to be a position called Sdtm programmer. So you are eligible for this one as a SAS programmer. If you do any one, at least one project, you can apply as an Sdtm programmer. Okay, then it's going to be Adam programmer. So if you learn all the guidelines and if you do at least one project, you can work as an Adam programmer. And in some companies, they are going to work only tables, listings, and figures or graphs. So you can work as a TLC programmer, as a SAS analyst. Some companies, they use end-to-end. From Sdtm to TLS, you are the only person who should do everything. Within a small company, but it's a big company, we are going to have separate teams for Sdtm, Adams, tables, listings. And again, in all the three concepts, we are going to have production side. So developmental side, you are going to be a developer, Sdtm developer, Adam developer, and a TLS developer. And there's going to be another position called validation. In the SAS program, based as I told you, we do double programming. The same program will be written by two different programmers. One program is called a developer, and another program is called a validator. The same work will do two different. The same code will be written by the two separate programs. So you can work as a what you call developer, or you can work as a validator. And apart from this, we are going to have a QC, quality control. So in SAS also we are going to have a QC. You can work as a QC programmer. And as a SAS programmer, you can work as a database developer. And now there is going to be a concept called annotated CRF sheets. You can work as an SAS programmer. You can also work as an annotated CRF sheet, creation or development, and you can work as a spec writer. That means you can create as specifications. So now we have a new concept called CDP, clinical data processing. So these are the positions that we have for a clinical, for SAS programmer. What is the title you get? Some companies will call you as a SAS programmer. Even though you are a clinical SAS programmer, simply they will call it as a SAS programmer. And some companies call it as a statistical programmer. Some companies call it as a clinical data analyst. And some companies may call it as a, clinical data analyst, clinical SAS programmer. All these are, same thing, but different. That companies use a different terminology for the role. And some companies call it as a DM programmer. Some companies call it as a, CDP programmer. All these are different companies use different names. Okay, now, so So since you have already completed the base and advanced, some of you might have completed the advanced, some are like haven't learned it. But with our base and advanced, if you have any proper Cdisc skills, you can become a good SAS programmer. So I told you we are going to have three important guidelines called Sdtm, Adams, and tables listings and graphs. Right now, there is a huge demand for Adams, tables, and listings and graphs. So if you learn this Adams, tables, listings, and graphs properly, definitely you are going to get a chance to become a clinical SAS programmer. And this is in huge demand, and you are getting a better pay scale. And some companies, they will offer only Sdtm programming jobs. And some companies offer separate Adams and TLFs, as in a separate role. But some companies, they will ask you to write end-to-end programming. Okay. Generally, if you want to keep 3 years or more than 3 years experience, you should have any skills on all the three. Okay. And apart from that, along with these three, you should have any skills on CRF sheet creation, specification sheet creation, and there is going to be a concept called Pinnacle 21. You should use that Pinnacle 21 also. So what we are going to do next 2 to 2.5 months time, I'm going to start with Sdtm, and I will ask, then after that we are going to do Adams, tables, listings, and the graphs. Okay. If you want to go as an Sdtm programmer, by the end of the first month, you can apply for jobs. You can upload your resume in the Naukri. But if you want to wait, if you want to have all the skills, you have to wait 2 to 2.5 months to complete Sdtm, Adams, tables, listings, and everything. Okay. As I said, 30 to 40% companies, they are offering only Sdtm. So if you want to get an Sdtm programmer, after 1 month, you can apply for the job. Understand? But my strong recommendation is, if you want to keep more than 1 year experience, 3 or 4 years, have a strong knowledge in Adams tables, because there's a huge requirement and demand for the Adams and TLS. So if you learn that 100%, you will get a chance. Okay. But you want to become a good Adams tables TLF programmer, you should have a strong knowledge already in Sdtm. Okay. Where the problem will come. Most of the students, by the end of the Sdtm, they don't do practice properly, and they will get saturated. They will satisfy with only Sdtm. They don't do proper practice. And if you do not do proper practice in Sdtm, Adams are going to become very, very difficult. Okay. But from the starting itself, be regular, be prepared for Sdtm. If you are full-fledged prepared for Sdtm, then Adams and tables and listings are going to be very, very easy. Because if Sdtm is 80%, in that Adams is going to be only 50%. In that Adams, again, tables and listings are going to be only 30%. But people get saturated because of the lengthy course. By the end of the Sdtm, they will come to saturation when they don't do properly Adams and tables. But if you have a proper Adams and tables and listings knowledge, you can definitely you'll get a chance. You can become a good SAS programmer, a clinical SAS programmer. Understand this one? So our strengths are going to be, and one more important thing, most of the institutions or faculty members, they never discuss about Adams and tables and listings, because even they do not know about this one. Okay. Our strengths are going to be Adams, tables and listings, and graphs. So you should use it for our advantage, and at least if you perform to intermediate level, definitely you'll get a chance. So our main focus are going to be, of course, we do Sdtm, lot of Sdtm work, but our goal is going to be Adams, tables, and listings and graphs. Okay. But as I said, the course is going to be next 2 to 2.5 months time. But if you want to get a fresher, or with 1 or 1.5 or 2 years experience, you don't require 2.5 years content, because I'm going to give the content keeping in focus of 3.5 to 4 years experience person. You can stop it anytime. You can apply for a job after 1 month. If you want to go as a fresher, or like in 1 year or 2 years experience. Okay. But as a clinical SAS programmer, I'm working for an industry. There is no limitation for any domain. So it will take 3 years, 3 months, 4 months, and 5 months also. but we need to stop it somewhere. So we'll make it as maybe 2.5 months course only for clinical project, and I will let you know that when you can apply for a job for what experience. Understand this one? But be prepared for that one. If I say that like tomorrow you can apply for the job, you should be ready to apply for the job. Understand this one?
Yes.
And the next important thing is, you should cooperate with me. If I say do this work today, and you have to complete that work by tomorrow morning, by the next class. That is how we should learn. There will be no gap between our final class and applying for the job. If I complete the class today, you should be ready to apply the job by tomorrow. That is how our course is going to be. Okay? Later the course on I want to have some time to prepare, and then after that I will apply the job. It doesn't work in that way. Understand this one? And one more important thing, I can guarantee you one important thing. If you are going as a 3.5 to 4 years experienced person interview, for an interview for 3.5 to 4 years, trust me, you are going to get the questions only from the classroom. You will not get one extra question. 100% we are going to cover all the questions. You are going to get the questions only from the class. And at the end of the class, don't ask me, give me some important interview questions or something. There is no such important interview questions at all. They can ask you from anything, from anywhere. Understand? But I can tell you one thing, we are going to cover each and every concept that what they're going to ask you in the interview. Understand this one? Okay. So this is about the introduction. Now we are going to start how the clinical data flows in a clinical research. How we conduct the clinical trial data. And I told you, all the pharma companies, once they got the permission to conduct the clinical trials in humans, how these companies will conduct the clinical trials in humans. Say, for example, now you are a CRO company. You got a contract from maybe Novartis or maybe Pfizer or GSK to conduct a clinical trial for phase 1, or maybe for phase 2, or maybe for phase 3 or phase 4. How we are going to conduct a clinical trial? What are the steps involved in a clinical trial? Okay, the first and foremost step that we are going to do whenever we want to conduct any clinical trial. Just imagine, you are in a pharmacy college, and you are doing your pharmacy course, B.Pharmacy or M.Pharmacy, or maybe BSc or something. When you enter into that lab, so today you have to conduct a lab practical. How we are going to start with? What is the first thing that you are going to do? So whenever we want to conduct any practical, the first thing that we are going to do, we are going to write. What we are going to do? We are going to write a protocol. So in clinical trials also, whenever we want to conduct any clinical trial phase, maybe phase 1 or a phase 2 or a phase 3 or a phase 4, the first thing that we should have is a protocol. What you are going to do? First, you need to write a protocol, and that we call it as a protocol design. We have to design a protocol. Have you ever seen any protocol in a college? In the college lab? How protocol looks like? What are the important subheadings we can have in protocol? Very good. The first important thing that we are going to have aims and objectives. So here also we are going to have aims and objectives. What do you mean by aims and objective? What is aim and objective? Why we are conducting this clinical, this practical, isn't it? So the first question is why we are doing this one. Why we do the phase 1? Why we do the phase 2? Why we do the phase 3? That is going to be your main objective. Okay. Now my question is, what is, efficacy if it is a diabetic drug? What is an efficacy for a diabetic drug? How we can measure the efficacy? If you have a temperature fever, how do you know that you have fever? How we can understand rise in temperature?
By using thermometer.
Yeah, very good. If it is a fever, you can feel it. or otherwise you have to use a thermometer to measure the temperature. So by seeing that, say for example, the normal temperature should have a 98.6, but you have a 100.2 or something. So what you can say, so you have a fever. Then what you will do now? You will take any medication, paracetamol or a dodo or glycol, whatever it might be. You take some medication, and after 6 months, again you measure the temperature. Now this time the temperature again we have a 98.6. Then what you can say? The temperature is normal. You have out of the fever. So that means if you want to prove the efficacy of my diabetic drug, how we can prove the efficacy of my drug? Blood sugar levels. So how we can measure the blood glucose level? Say for example, before the treatment, I measure the blood glucose level of a patient. Okay, and the blood glucose level was, say for example, 350. Okay, now I started giving my medication, my drug, my XYZ drug. Okay, and I have given this drug for 3 months. After the 3rd month, again I measured the same blood glucose level to the same person. Now this time the blood glucose level is, say for example, 140 or something after the breakfast. So can I say my drug is working? Of course, if a drug is working. That means now if you want to measure efficacy of my drug, now if you want to say scientifically, what is the efficacy of a drug, how we can put that one after the 3-month study, if the blood glucose level come to 120 μg per ml, and then I can say my drug is working. So in this scenario, in this example, what is our primary objective of our study? What is the aim of our study? Reducing the blood glucose level is the primary objective of my study. Diabetic drug and diabetes drug and ఎవరైనా పనిచేస్తుందండి. It is going to work on, most of the time it is going to work on blood glucose level. Isn't it? So the primary, if you want to say more scientifically, what is the primary objective of study? Even a drug, if it comes with a diabetic drug, I would say the primary objective of my study, my drug is a reduction in the blood glucose level after 3 months study, 3 months treatment. So if I say my drug is say for example, a blood pressure drug, then what I should say, say for example, my treatment is a 3 months treatment. After 3 months, what is the reduction in the blood pressure level, after 3 months treatment? ఎంత తగ్గిందనే దాని basis pay, I can prove my efficacy. Say for example, it's an oncologist, tumor, what do you call the oncology drug, cancer drug. How we can prove the efficacy? At the starting, there was a tumor which contains a 20 millimeter. After 3 weeks or 3 months of my drug usage, now there is no increase in the diameter of the tumor. So I can say that my drug is working. There is no further development, there is no further increase in the size of the tumor, or that the tumor has been started shrinking and it has become now the 10 mm tumor. So now what is the primary objective of study? Reduction in the size of the tumor. And there is no increase in the size of the tumor. Understand, say for example, some cancer drugs. Once you got the cancer, you have to die. That's the reality, hard reality. Isn't it? Now, say for example, if the patient is not using the cancer medication, he is going to die in 3 months. If I give my medication, if that survival has been increased from 3 months to maybe 2 years. So that is the primary, my efficacy, my objective of my study. Increasing the survivability and increasing the duration or increasing the lifespan of that patient, that is going to be my primary objective of the study. So each and every study is going to have an objective of the study. And that is going to come under aims and objectives. Understand this one? So we are going to have a purpose why we are doing the study, and you should write that one that comes under aims and objectives. And the second important thing is each and every study is going to have a secondary objective, and you should write that secondary objective also. I'm going to give you a couple of protocols. Maybe tomorrow or day after tomorrow, you have to see that what are all the important subheadings that we have. And you need to understand what is the primary objective in the protocol and what are the secondary objectives. Because in the interview, they will ask you a question. What is the current project that you are working on? And you are going to tell the title that what I'm going to give it to you. So I'm working on a double-blind, randomized, a crossover study, and it's a diabetic study. It's my drug versus a study medication. And then they will ask you, what is the primary objective of your study? Where we can find the primary objective now? We can find in the protocol. Okay, and then they will ask you, what is the secondary objective of your study? Say, for example, with a phase 2, primary objective is efficacy, and the secondary objective is going to be the safety. Now, how we can prove the safety? Again, I'm going to say take some test reports, and I'm going to measure some indication based on that I can prove my efficacy of the safety. So each and every study is going to have secondary objective, and you should know the secondary objective, and that information you can find in the protocol. Say, for example, I'm taking my diabetic drug, XYZ drug. The XYZ drug, the primary objective of this drug is reduction in the blood glucose level. This is the primary objective. There's only one primary objective. So this is the primary objective. Now I'm very strongly believing that my drug is not only going to reduce the blood glucose level, it will also reduce blood urea and serum creatine also. Now that is going to be my secondary objective of the study. So each and every study is going to have the secondary objective also. And you should understand, and in the interview, they're going to ask you very frequently, what are the secondary objectives of your study? And you should tell them. So in this example, the secondary objective of my study is, so for example, reduction in serum creatine, or maybe reduction in the blood urea. Those are, my secondary objective of the study. Or maybe I'm strongly believing that my drug is going to working on diabetes, blood glucose level, and I'm strongly believing that my drug is working as a painkiller also, as a secondary objective. So for example, if you take Sdtm, how it is going to work? It's going to work on fever because it is going to have a paracetamol, and is also going to have it's going to work as going to reduce the as anti-inflammatory or something, going to reduce the body pains. Isn't it? So some drugs, not some, all the drugs are going to have a secondary objectives, and you should understand, and you should know that one, you should take them. Understand this one? Now, the second important thing is, in the protocol, the most important thing that we are going to have, which subjects you are going to take for your study. This study లోపలికి మీరు ఎవరిని తీసుకుందాం అనుకుంటున్నారు? So for example, tell me, it's a phase 2 diabetic study. Whom you have to take into the study? Obviously, the subject has to have a diabetes. నాకు diabetes లేదు, but still I want involvement తీసుకుంటారా? They don't take you. So, who we have to select into our study? We are going to write few rules, and those rules are called inclusion and exclusion criteria rules. ఏమంటామంటే వాటిని మనం inclusion and exclusion criteria, and this is called screening rules, screening procedure. ఎవరిని ఈ శైలిలోకి తీసుకోవాలి, ఎవరిని తీసుకోకూడదు. So we are going to have inclusion criteria, and then we are going to have exclusion criteria. If you want to learn SAS, what is inclusion criteria? You should have at least graduation. Without graduation, can you become a SAS programmer? No, because the mandatory qualification, the basic qualification must have a graduation. It may be B Pharmacy or BSc or BTech or BDS, whatever it might be. There's going to be certain guidelines, right? In the same way, if you want to involve and if you want to take any person into the study, that subject must follow some rules. He must satisfy some rules, and those rules are called inclusion criteria. Now I will tell you a few inclusion criteria rules. If anybody wants to involve in my phase, say for example, I have given a paper notification. So I want to, I'm conducting clinical trial in NIMS hospital. It is a diabetic study. I'm doing phase 2 study. Okay, phase 2 study. And I have given a paper notification. If anybody wants to, if anybody are interested in this clinical trial, you can enroll yourself and I'll tell them, I'm going to give you a free medication. For each visit, I'm going to give 2,000 rupees, and I will tell you all that, what and all I'm going to do. Some people, they get involved in the clinical money I'm giving, or sometimes, as a responsible person, he wants to contribute something into the society. Voluntarily, he will get involved. Understand? Because of that, so many reasons, so people will show the interest they want to involve in the clinical trial. So they will come and they will enroll. So, for example, it's a phase. I want to have 1,000 subjects in this study. Diabetic study is a NIMS hospital, is a government hospital. So many people will come, and definitely I'm going to get, all the 1,000 patients. And by the way, the reason why India or Hyderabad is so big hub for the clinical trials, getting the patients at a cheaper price. Sometimes we are going to get the more and more, patients. So because we have high population country, and we are going to have, people, if you are giving a free medication, definitely they will get involved. So getting the patients is going to be easy in particular South Asian countries. So that's why we are big hub for clinical trials. Understand this one? As soon as given the paper notification, and then, I want to have 1,000 patients, 1,000 subjects, but 2,000 patients or subjects have been enrolled in my study. Am I going to take all the 2,000? Whoever get involved, am I going to take everybody? No. Now, whenever the subject comes to that for the first time, now in the protocol, I'm going to write a few inclusion criteria rules. The first rule that what I have written, whoever get involved in, whoever wants to involve in my clinical trial, that person should have age between 18 to 65. This is the first rule. I'm going to check whether the subject is satisfying this condition or not. If your age is less than 18, I won't take you. And at the same time, if your age is more than 65, I will not take you. So whoever wants to involve in my clinical trial, his age must be between 18 to 65. Understand this one? Now, what are these questions? These are called inclusion criteria questions. Whatever the questions I'm going to write in the inclusion criteria, all the questions must answer yes, then only I'm going to take the subject. He is 18 to 61. If you say yes, I will take you. If you say no, I won't take you. Understand this one? And the next one, it's a phase 2 study. Obviously, whom I'm going to take? Are you a diabetic patient? Are you a diabetic patient? If you say, yes, I'm a diabetic patient, then only I'm going to take you. If you say, no, I'm not a diabetic, I won't take you because it's a phase 2. Now, yes, what I will to know? I will take a sample, I will run the blood test, and if you have a diabetic condition, then only I will take you. So that means during the inclusion criteria, this is called screening procedure. I will take the blood samples from the person who wants to involve in clinical trial. I will run all the necessary tests. If he is satisfied, if satisfactory with the test reports, then I will take the person. Now, based on that, I'm going to have few exclusion criteria questions. The exclusion criteria questions that we have, whatever the question that I'm going to write in exclusion criteria, the answer must be, then only I'm going to take the subject, otherwise I'm not going to take the person. So inclusion criteria questions are yes, I will tell you. Exclusion criteria questions are around the no, I will tell. Say for example, inclusion criteria rule rastan chudandi, whoever wants to involve in my clinical trial, okay, that person must have a hemoglobin between 9 to 14 or something. 9 kana takuna tiskono, 14 kana ikkona tiskone. If the hemoglobin is HB counts is between the 9 to 14, I will take only that person. Now I'm going to measure the hemoglobin level, and based on that, I'm going to decide whether I should take that person or not into my study. And again, the next one, we are going to have exclusion criteria. The exclusion criteria question, the first one is going to be, are you a cardiac patient? You say yes, I won't take you. Okay, if you say no, I will take you. Because of, according to my study, I do not want to include any cardiac related, patients. So if you have a cardiac problem, then I won't take you. Otherwise, I will take you. And the second question is, so are you pregnant or planning for pregnancy or you're lactating mother? Okay, if you are pregnant, I won't take you. And if you're planning for pregnancy next 6 months, and I will not take you. And if you're a lactating mother, I won't take you. Because in my study, I do not want to take any pregnant women and lactating mothers or planning for pregnancy. If you say yes, I won't take you. If you say no, I will take you. And the third question that we are going to have is, are you allergic to any drug? If you say yes, you say yes, I won't take you. If you say no, I will take you. So now depends on the study. I am going to inclusion criteria and a few exclusion criteria rules. And if you satisfy with those rules, if I'm satisfied with those rules, that if you are, fulfilling all those rules, then I will take the subject. So where we can find this inclusion criteria and exclusion criteria rules, now we can find all these rules in the protocol. So before the study, I'm going to design the protocol. So that is called protocol design. Okay, I'm going to write all what is my primary criteria, secondary criteria, how many subjects I should take, what type of population I should take, should I take only males or females only, or both and males and females, how many subjects I should take, what is the inclusion criteria, what is the exclusion criteria, how many visits I'm going to have. Do you know what you mean by visit? That means how many times the subjects should come to the hospital, what is the duration of my treatment, what is the end point. Each and every study is going to have an end point. What is an end point? Say, for example, it is a diabetic study. I planned for 3 months. It's a 3-month treatment. Okay, so I have to give the treatment for 3 months. I'm taking a subject called X. Before the treatment, this subject has got glucose level 350. Okay, in the second visit, it came down to 200. In the third visit itself, it came to 110. Am I going to continue the treatment? Will I have 4 to 5 visits? I'm not going to. If I continue the treatment to this person, what will happen now? He's going to become hypoglycemic because he already came to normalcy. When he is in normal condition, why we should give the treatment? We should not give the treatment. So each and every study is going to have an end point. If the subject is meeting that endpoint before the completion of the treatment, I should stop the treatment to the person. So each and every study is going to have an endpoint, and you should know what is that endpoint. And that information you can find again in the protocol. Understand this one? So if the subject is meeting that endpoint, we should not continue further for the treatment. We should stop that one. We should ask him to leave the clinical trial because he already came to normal. So we should know that what is the endpoint that we have in the study. That information also we can find in the protocol. So we are going to design a protocol. Once the protocol design has been completed, if the protocol design completed, the next step that we are going to do, we are going to design a CRF sheet. What is CRF sheet? Case report form. What is a case report form? How it looks like? Whenever you go to the hospital for the first time, say for example, there is a person, your grandmother, and you have a doubt that she's like a maybe diabetic. So far, she's not in a diabetic, and you're thinking that she has got diabetic symptoms. So you have taken her for the first time to the hospital. Whenever you go to the hospital, what the doctor will do, whenever you pay that what you call consultation fee, they'll give you a file. In that, they will take the medical information, the gender of the person, they will take age of the person. First time, they will take the temperature, they will take height and weight also. Then they will take the patient to the doctor. Now the doctor after doing the preliminary checkup, and he will suggest few tests. Okay, and they will ask you to go to the diagnostic center and give the blood sample and undergo these tests. And the doctor has given blood post that all the blood profile, hemoglobin, WBC, RBC, CRP count, and even he suggested HRCT scan, and he suggested all the, say for example, he has suggested 50 tests. Now you will take your grandmother to that diagnostic center, and you guys are going to give the samples. Maybe after 4 hours or 5 hours, you'll get the sample test reports, and the diagnostic person, the lab person, is going to give all the test reports in a form of some paper slips, and those paper slips are nothing but CRF sheets. So where we have the blood reports, those are just like in a CRF sheets, case report form. But in the real time, those are not so organized. But in a clinical trial, those CRF sheets are very, very organized. So in reality, in clinical trials, CRF sheet is the heart of the clinical trial data. 80% of the data we get from the CRF sheet. Okay. Now, when a subject goes to the clinical trial visit, okay, we take the blood samples from the subject and we'll perform all the tests. When we got the test reports, where we enter all the test reports, we enter all the test reports onto the CRF sheet. It's just like an application form. When you're applying for a job or when you're applying for next course, you are going to fill an application form, right? You have to give all the details. In the same way, when you perform the laboratory test, we get the lot of test reports. We get all the test results into the CRF sheet, and that's why this is called a case report form. And 80% of the data in the real time we get from the CRF sheet. Understand this one? Say for example, this is the clinical trial. In this clinical trial, I am having say for example, 6 visits. So this is the first visit, visit 1, and then I'm going to have a visit 2, then we are going to have a visit 3 and visit 4, and so on and so on. According to protocol, during the first visit, okay, I have to take the ECG of the subject. Now in the CRF sheet, in the first visit, I'm going to keep in a column what is the ECG report. Once you perform the ECG, I need to collect that information. I need to enter that information in the CRF sheets, visit 1. During the visit 1, I have to take height value of the subject, I have to take the weight, and I have to take the BMI, and I have to take the temperature, and I have to take the systolic blood pressure, and I have to take the systolic blood pressure, and I have to take the diastolic blood pressure. So I am going to put a column for each and every test in the CRF sheet. Now when you perform the test, what you will get now? You will get the reports. Now, as a doctor, I'm going to fill the CRF sheet with all the blood reports. By seeing the reports, I'm going to fill the CRF sheet. So now where we have all the results now, we are going to have all the results on the CRF sheet. So we are going to design the CRF sheet in such a way that by reading the protocol, you can understand what are the tests we need to perform in each visit. According to that, we are going to design a CRF sheet. We take ECG, but we never take ECG in all the tests, all the visits. Whenever you are entering for the first time, I want to know how is condition of, so I will take the ECG for the first time. But I don't do ECG for every test. Maybe before leaving again, in the 5th visit, again I will take the ECG. So I need to have a column in the CRF sheet only for visit 1 and visit 5 for ECG. And I don't need to have that column for each and every visit, isn't it? Because I don't collect ECG reports for every visit. And I will collect only height in the first visit and the last visit. I don't collect height in all the visits. So now I do not require height column in each and every visit of the CRF sheet. So according to the protocol, now we are going to design a CRF sheet. And previously, 4 to 5 years back, we used to have only paper CRF sheets. We used to have only paper CRF sheets. That means it's going to have a hard copy. When the subject comes to the hospital or clinical site, we collect the samples, we run the test, and we get the test reports. Now the doctor will fill all the CRF sheets by seeing the test report. But now the eCRF sheets has been replaced by the paper CRF sheet has been replaced by eCRF sheets. Now, what do you mean by eCRF sheet? Electronic case report form. What is the disadvantage with the paper CRF sheet? Paper CRF sheet prone for errors. When the, say for example, doctor entering the data onto the paper CRF sheet. The age of the subject is, say for example, 23. Just imagine. So on a paper CRF sheet, how we enter the data? By writing through handwriting. So when the doctor entering, he has entered 23. But unfortunately, his handwriting was not so clear. And he entered 3 as an 8. It's confusion between 3 and 8. So now, the next after the CRF sheet, this CRF sheet will go to the CDM department. Now the person who is in the CDM, that person should enter the data from the CRF sheet into database. While entering the data, he thought it was a 28. Because there is a confusion, like he overwrite that one, so he thought it was 28. So he's going to enter the data as a 28. So there is a discrepancy. There is an error. There is a mistake. So paper CRF sheets are prone for errors. If it is an eCRF sheet, it is going to online form. You can enter either 3 or you can enter either 8. There is no ambiguity, there will be no confusion in it. మీరు ఎప్పుడైనా ఆన్లైన్ లో అప్లికేషన్ ఫిల్ చేస్తున్నారు అనుకోండి, you should enter any one value. There is no scope for like an error or confusion. So that's why eCRF sheets are better than the paper CRF sheets. But again, there is a problem with the eCRF sheet. If it's a paper CRF sheet, once the data has been entered, the doctor is going to sign under the paper. So then there is a proof. There is an authenticity for the data. There is a guarantee for the data. But if it's an eCRF sheet, do we have any guarantee that the data is authenticated or is the data is true? We don't know that who entered the data. Isn't it? If you're doing an online exam, there's a chance of somebody can attend on your behalf of you, right? But is it a paper-based exam? In person, you have to attend, and there is going to be some invigilator. Is going to check your hall ticket number. Is going to check your photograph, and then you can decide that you're the right person. But is it an online exam? We don't have that guarantee. So in the same way, if it is an eCRF sheet, we are going to fill the information online. So then what is the guarantee that the same doctor, only the authorized person enter the data? That's why, American government developed a regulation. And that regulation, anybody knows what is the regulation called? 21, CFR Part 11. What is the 21 CFR? What do you mean by CFR? Code of Federal Regulation. అంటే మనకి ఎలాగైతే ఇండియాలో కాన్స్టిట్యూషన్ ఉందో అలాగే అక్కడే ఉంటారంటే CFR అంటాం. Code of Federal Regulation. In the Part 11, there is an A clause. When you're entering the data online, we need to submit electronic signatures. All these electronic signatures, and what you call facial recognition, OTPs, captchas, and what you call credentials, and all these thumb impressions, biometric, all this comes under this 21 CFR Part 11. So by using this online electronic signatures, we can make it more and more authenticate the data. So we are going to provide only those credentials to the right person. By entering those credentials only, he can enter the data. And nobody can, enter into that one. So if somebody wants to enter into that one, you need to fulfill those credentials, those electronic signatures, and OTPs and other. By following all these predictive measurements, we are going to make it the data more and more authentic, more and more genuine, and more personal. And again, at the end of the clinical trial, we have to submit all the CRF sheets to FDA. If it's a paper CRF sheet, we are going to have huge bundles. Again, when you're shipping these bundles, these are prone for damage. But it's an electronic CRF sheet. You can put everything in one hard disk and you can transfer that hard disk to, regulatory body. So shipping of this, EA CRF sheets are going to be, because we are going to transfer online. But in the paper CRF sheet, there's a prone for damage. That's why, eCRF sheet, electronic case report forms has become now mandatory in all the clinical trials. So we are going to design the CRF sheet, and I'm going to give you two CRF sheets. Please follow through those CRF sheets. Try to find out what information that you can collect into the CRF sheet. Get familiar with those CRF sheets. Okay? Because as a programmer, sometimes we are going to get directly CRF sheets. We need to enter the data into Excel sheets. Then we need to import those Excel sheets, and we should convert them into, again, later into data sets. Okay? I will provide you 2 to 3 CRF sheets. Understand this one? Now, once you're done with the CRF sheet design, and the next thing we are going to design database. So third one is database design. So we'll continue the database design in the next class. Next 2 classes are going to be theoretical classes. Maybe from Friday, we'll start with actual Sdtm. Okay? Maybe Thursday only, we start with the actual Sdtm.
What about
By the way,
macro?
I will tell you when we should start reading, what we should start reading, which pages you should start reading. I will give you all the documents and I'll let you know from where we should start reading. Okay? Okay then. See you tomorrow.
Sir, good morning, sir. Srinivas, sir. Hello.